Good morning, everyone. And I'll be talking about this situation, vision loss with normal fundus, a situation which is not so uncommon in our day-to-day practices, clinical practices. And it holds importance because this situation creates a big psychological impact for the patient, because he's told, doctor tells him, see, everything is looking normal, but the patient is having vision loss and he just can't understand it. He wonders whether there's something wrong with him, and that's important. Then there's a financial burden on the patient because there are so many excessive investigations that he's asked to do, get an MRI, repeat MRI, this and that. And then there's a medical legal implication, because you often have to declare whether the patient now has any handicap. Does he actually have so? Or there are lawsuits or cases which also require a medical legal consultation, and this is a problem there. This can happen actually. There are many causes which can actually cause vision loss, and the fundus may appear normal, and they could be related to the macula, to the optic nerve, to the cortex, or they could be functional malingering causes, and there are a lot of other neurological causes that we'll also come to. To begin with, first of all, from before backwards, we'll start with the macula. There's a group of disorders known as occult macular dystrophies. These are macular dystrophies which actually present with a normal looking fundus, and there's a progressive vision loss of the patient. And you do a normal ERG, you'd probably not get it because that's a full field ERG. So in such cases, an OCT will show you a thinning, and a multifocal ERG, for the central 7 degrees would be more specific. It'll show you a depression in the central 7 degrees, and essentially it's involving the cones. Then we come down to the optic nerve, and there's retrobulbar neuritis, and I think Professor Menon has taken a detailed lecture on that. And essentially what you need to know is, again, this is usually unilateral in young adult females. The fundus is normal in retrobulbar neuritis. Later on, disc pallor may develop, but in the acute phase there will be an RAPD, and patient will have color desaturation, contrast loss, visual field defects, which could vary from central scotomas to altitudinal to diffuse field defects, and one has to be attuned to be able to pick this up. The next, which is what we see a bit more rarely these days, is nutritional deficiency optic neuropathies. These happen because of deficiency of vitamin B1, B2, B6, some proteins as well, or severe protein deficiencies. And typically there's usually a bilateral symmetrical sort of a vision loss, and the visual fields would show you central scotomas, and over time there will be temporal disc pallor develops, and usually it's the mesopic vision which gets decreased first, and then the photopic vision. And once again, one has to look at this in cases of high risk cases, maybe chronic alcoholics, patients who've been on total parenteral nutrition for some time, or patients who've had a gross protein energy malnutrition. In those cases, you need to be looking out for the nutritional deficiency optic neuropathies. The next set of neuropathies that we look at are the toxic neuropathies. I think this is something we, as neuro-ophthalmologists and as ophthalmologists, will come across very often. The commonest and probably the most acute of these would be the methanol poisoning, which actually presents with a lot of systemic features, including abdominal pain, vomiting, and is life-threatening. And one has to take a detailed history of whether the patient has consumed any illicit alcohol in the near past. Sometimes the patient may not have had an acute attack, but over a long time period of having consumed alcohol, there's a chronic neuropathy which presents not with the systemic signs and symptoms, but with the optic nerve changes itself. Then there's ethambutol and chloramphenicol, and in fact there are many others, amiodarone, a lot of other drugs which are also responsible, and these are usually in a dose-dependent manner, and one needs to take a history of the patient having taken anti-tubercular therapy, and basically the treatment in this case would be to discontinue the drug as soon as you can, and isoniazid is also responsible for toxic optic neuropathies. And the fundus initially is normal, and over time you can probably develop a temporal pallor. The next is cancer-associated optic neuropathies. Now, optic neuropathies can be associated with cancer either because of direct infiltration or in a paraneoplastic format, or sometimes it's a toxic neuropathy secondary to all the drugs that the patient has been taken for the chemotherapy of cancer. And there's also cancer-associated retinopathy, which also sometimes would not show anything on the fundus, but you would have this classical triad where the patient is having ring scotomas and photophobias, and one has to have a high suspicion for this, especially if you're dealing with patients who've had pancreatic cancers. The next, we can move on to the Leber's hereditary optic neuropathies. About 1/5 of the cases would never show you any fundus changes, but the others would show some changes in the acute phase, maybe telangiectasias, peripapillary telangiectasias, or dilated tortuous vessels. And over time, it's usually a sequential. There's one eye involved first, followed after about a few weeks to a month with the involvement of the second eye, and it's usually in young adult males. There really isn't a well-defined treatment for this. Some new medicines have been tried now, idibidon, ubiquitin, but the trials are still on, and I think they've shown some success. But yeah, essentially it's hereditary mitochondrial inheritance is there, and as such we do not have a therapy for this. One can get a genetic analysis done in Leber's hereditary optic neuropathy, and that's basically to be able to prognosticate for the patient depending on the genetic defect that he has. The next we can move on to is the posterior ischemic optic neuropathy. Again, this can happen, after surgeries, after traumas, acute blood loss, or sometimes if the patient has systemic diseases such as diabetes, hypertension, where again the fundus appears absolutely normal. And the patient would usually have one eye involvement, sometimes both eyes involvement, but with vision loss, there is an RAPD, and again one has to have a high suspicion to be able to catch these. The next that we move on to are traumatic optic neuropathies, again something that we often come across. These could be either because of direct trauma or indirect trauma. Direct, if there is an optic nerve avulsion, then you would have some definite signs in the fundus. But in the indirect cases, early on, you would just probably have a relative afferent pupillary defect, but the optic nerve and the fundus looks absolutely normal, and over some, let's say about a month's time, it will develop a disc pallor. So if there is an indirect suprabout trauma, that's where you need to suspect a traumatic optic neuropathy. Next we come to cortical visual impairment. So now we moved on to the brain. In cortical visual impairment, usually in cases of HIE or hypoxic ischemic encephalopathy or trauma or infections, you can have involvement of the occipital cortex or the parietal cortex, and that causes a vision loss. Usually if the occipital cortex is involved, it's going to be a bilateral and the pupillary reactions are normal. In some cases, the patient may actually have a microtropia or a small angle squint, and he develops an amblyopia along with that, and therefore you actually miss it. And one of the things that you can do is a 4-prism brace-out test. By putting a 4-prism in front of the eye, you can actually see that there's a suppression scotoma over the macular area, and there's a peripheral fields are normal, and there's a peripheral fusion. And sometimes microtropia would have identity, and in fact on your cover test you would not be able to detect it. The next is functioning, and this is something that often comes across, that is malingerers, who could be either positive malingerers or negative malingerers. Positive malingerers meaning they pretend to have more vision than they actually do, and negative is they pretend to have a vision loss. And again here medical legal implication becomes very important, and the ophthalmologist has to be smarter than the malingerer to be able to catch the malingerer. There are many tests defined for malingering to be able to detect it. I think this is a comprehensive list of the tests that can be done. Probably for bilateral blindness, the attitude of the patient is important. You can do a menace reflex, that is take an object very close to the patient's eye if he's pretending to be blind, and anybody out of a reflex action would blink his eyes. The idea is not to touch the eyelashes. You can do an optokinetic nystagmus. You could do a visual evoked response, an ERG, and in all of these cases you'll actually see a response coming on the electrophysiology. For unilateral blindness, you can actually look at the stereoacuity. You can do a fogging test. Stereoacuity, if the patient is having a stereoacuity, then obviously he's not blind in one eye. He has to be seeing with both eyes to have a stereoacuity. For the fogging test, you get the patient to read a Snellen chart while you quickly put a +3, +4 lens or +5 lens in front of one eye, and if he continues to read, that means that eye actually has vision and he's just malingering. It's more difficult to detect patients who are pretending to have just poor vision and not total blindness. But then again, you can still use the fogging test. You can make them read the Snellen chart from different distances, and you can see the consistency in response. And it's important to know that in malingerers, there's often an inconsistency in how the patient responds to different tests. The next in function comes hysterical blindness, and there are a few others, but hysterical blindness is actually a psychiatric problem, which the patient actually is not aware of the fact that he's actually pretending to be blind, and in that case a psychological consultation and psychological treatment is required. In some of the other causes that we look at, there are neurological causes such as TIA attacks, and TIA attacks can happen in vascular disorders, cardiovascular disorders. You can often do a carotid Doppler, you'll be able to find small emboli which are going there. Then sometimes in migraines, you can have vision loss. In hemianopias, you can have vision loss. The patient the fundus may actually be looking absolutely normal there. So to conclude, one has to be an astute ophthalmologist to be able to detect these small subtle signs and symptoms, and one has to order the right investigations, and then one can actually diagnose most of these cases, in fact all of these cases, and definitely one has to be on the lookout for malingerers as well. Thank you.